Right, so for 3, you have the triangle, but the hair is still going to be thin and fairly wispy, sparse, okay? Stage 4, you're going to have now more curled, thicker hair, and it will fill the area completely. But similar to the girls, it stays at stage 4 until you have hair on the medial thighs. Certainly, you also can look at the size of the testes in terms of using an orchidometer to see where they would fit. Most of us don't own an orchidometer, so we wouldn't be asking you to do that. But definitely the hair you want to be aware of. Okay?
Okay, thank you.
No problem. All right, so I think I have a few names that I can harass now. All right, let's go back to our share. Okie dokie. All right. Okay, guys. Oops, missed a slide. So sexual development, really remember to consider as you're going through the sexual development other things. So, you know, their own perceptions of their bodies, the biology and genetics. So, for example, girls' pubertal maturation is very closely matched to their mother's pubertal maturation. So if you have a mother who had menarche at 11 and her daughter is not having menarche and she's now 14 and a half, you want to watch that girl far more closely than if her mother had her period at 14 or 15, would be far less concerned, okay? And the same is true for the boys. You want to look at personality characteristics as well, and the socio-cultural values and norms. What some of the things that we do know is that girls who develop earlier are more likely to engage in high-risk behaviors, and boys who have delayed pubertal development are more likely to have challenges with their self-esteem. Okay, so just things to look out for and to be aware. So if we are aware of the likely challenges that we're going to have, we're going to watch out for them more closely and monitor and give anticipatory guidance. Okay? All right, now brain development. It's a process going from caudal to cephalic. And, some basic stuff is in the caudal area, like just maintaining your vital signs, making sure that you feel full. And then as we start to hit adolescence, we start to have the limbic system kicking into gear. And this is when you get a lot of the emotional reactivity, the kids that fly off at the least little thing, more resistance to rules and guidance. But that's their job. That's what they're supposed to do, right? So it's not that they're trying to be over the top. You just have to make sure that the boundaries are there. The parents know how to maintain the boundaries appropriately. So you're not going to lick down a picnic. You're not going to lock them up and them can't go nowhere at all, because then they'll just teeth out. So we just have to recognize that this is a process, okay? And then now we get to frontal cortex and prefrontal cortex, which is going to be the last part to develop. And that now is going to be responsible for controlling stuff. So the limbic system is really, quite entertaining that it comes earlier. This is where you get, that seeking of gratification, the immediate gratification. You have to get the reward and the pleasure right now. It also, though, is responsible for adolescents having difficulty interpreting what parents are thinking and adults are thinking. So, they do something, they teeth out the car, crash the car, almost died. And when the parents are looking at them in total abject panic, an adolescent can misinterpret that as anger. Okay? So just be aware of that as you work with your young people and with parents as you go out into the world in just a year. All right? The prefrontal cortex now, as I said, it develops a little later. It continues to develop. We used to think up until about 24. They're now thinking it may go up to 27, 28. So this is the part that allows you to regulate the emotions, to weigh your pros and cons and make decisions. It allows you to actually effectively multitask and, just overall self-awareness, self-control, knowing how to move forward. Now, the social brain is a fairly new concept. I would say maybe in the last 10 years, they've been doing a lot of work on this. And this is the part that adolescents really struggle with, being able to understand people. A lot of them, well, by nature, adolescents are narcissistic, right? And I think the world revolves around me. But also as they're going through the whole concept of change, this is where they're trying to figure themselves out. They're highly self-conscious. They compare themselves with other people, their peers. And it's as they get older that they become more capable of managing complex relationships. And that's why young people in very complex relationships, when they're in early adolescence, it can go very badly because they really don't know how to manage that. And that is the primary reason why you don't want a 14-year-old dating a 25-year-old, because he or she at 14 just cannot reason with the 25-year-old on the same level. Well, certainly not somebody of normal intelligence, right? In addition to this, from a developmental perspective, adolescents are far more sensitive to peer rejection and acceptance than adults are. So, you're 30 and your friend kick off and tell you something highly inappropriate. You're like, oh, okay, he's going through a rough time. It will sort out itself by next week. Whereas adolescents can implode when that sort of thing occurs. Can't forget the hormonal factors. A lot of things are going on, and all of these can affect brain development and behavioral tasks, right? It can change your perception, your motivation, lots of things. A couple that I just want to mention quickly would also be dopamine, that adolescents have a far larger surge in their dopamine levels when they are engaged in a pleasurable activity. And so that can make it really problematic. But it also guides us to know that, okay, you have a 15-year-old who started having sex and she decides she's never having sex again. But in your head, listen, man, that was essentially consensual sex. She enjoyed it. She feel like, okay, she really shouldn't have done it. But you know that in 2 months' time, if the opportunity presents itself, she'll probably have sex again. And that is just because there is this desire to feel that surge of dopamine again. It's a wonderful surge. Why wouldn't you want to go for it again? So in those situations, you have to be very careful. Do we start this young person on contraceptives? Okay. Oxytocin, no, and that's for boys and girls. The same thing happens, right? It's just that most people won't believe the boy when he says that he's not having sex again because we're socialized to think so. Oxytocin now is a bonding hormone, which once there is any significant interaction, doesn't have to be physical, just has to be a significant connection. You have a surge of oxytocin in the females. And this is why females are not good at casual sex. There are a few that can manage it, but for the most part, female adolescents are not good persons to engage in casual sex. It just doesn't happen. It always affects them more than it should. There's no always, but let's say 99% of the time. All right, so what are some of the health challenges that you're going to encounter? Maybe I should have asked you guys this, but going through mental health, probably at the top of the list. So the truth is, most adolescents don't have a lot of physical ailments. You have those who may, and you have those who will have a chronic illness, but they're still going to be the smaller proportion of the adolescent population in total. So most adolescents, physically very healthy, but a lot of issues with mental health, and this can affect so many other aspects of their life. A lot of issues with risky behaviors that can affect you later down in terms of premature morbidity and mortality. So, we want to look at the huge gray cloud that is over us in terms of COVID. I would hazard a guess that none of us in this room currently did not experience physical responses to COVID stress. You just, physical response, you just feel tired all the time, or you just feel like, oh, You just feel unmotivated. Everybody went through that at some point or another, and you hope that most of us in here have been able to ride the wave and we're back to where we used to be, okay? Some still struggling, and that's just par for the course. Sexual and reproductive health issues, big issue. Gender-based violence, big issue. Culturally, I think we're making a shift with gender-based violence, but not a huge enough shift in terms of the recognition of females or vulnerable people. I shouldn't say just females, but vulnerable people being taken advantage of. So whether it's a young female and a 30 or 40-year-old man, or a young male and a 30 or 40-year-old woman. I've had a few of those cases where the boys have been brave enough to share their experience about women approaching them inappropriately. But there are a lot of boys that are not going to complain about that as abusive, okay? All right, technology has increased in terms of its reach and expanse. Especially with COVID, parents just can't monitor as much because you know how it is. Probably even right now in this lecture, you have one screen up with me just in case I ask you a question, and then you have another screen that you're focused on, okay? So imagine you between 25 and 30 having that experience in comparison to a 15-year-old in a class. So we know that they're flipping screens. The things that we need to be concerned about, though, is engagement in cybersex, pornography, online gaming, and gambling. And a lot of young people don't realize that sharing photos of other people, whether it be their girlfriend, their friend, their boyfriend, whatever it is illegal, right? Once they're under 18, that's illegal. Even if you have their permission to be flipping this picture, it's illegal. We have to look at the challenges surrounding the LGBTQI community, in terms of just being able to access health safely, the stigma and discrimination that they may have. And then things like self-harm, that is on a significant increase, I think. It's one of the more common negative coping strategies that are utilized. Then we have disordered eating behaviors and then sleep challenges, okay? I think we spoke about all of these already. All right, so let me look and see. We don't have a lot of time. All right, so let's blow through. So good things for you to know. You need to take time with the adolescent. Sometimes those few initial visits that you have to put in a lot of effort to connect to the adolescent, they're so worth it. You know, like the first 1 or 2 visits, it might feel like really hard, but adolescents take time to decide if you are trustworthy. But once they realize you're trustworthy, you're good to go. They will work with you. So you need to show genuine interest and concern. You can't fake it, right? They will know. You need to be non-judgmental. Don't assume based on how they dress whether they're having sex or not. The fact that they have a tattoo, you know, they're likely to be smoking. No, none of that foolishness. You need to be yourself. You don't need to be cool. You just need to be you, and then you will come across as genuine. It tends to be a little hard for you as young physicians coming up because you tend to go through this phase, and we all went through it, where you feel like you know a lot, and that you can give information to the young person. You have to be very careful. You're not teaching them. You may advise, you may guide, but don't seem to come across as giving instructions. They'll just tune you out. You'll just hear the ears go click. Talk to the hand, my girl. That's what will happen to you. So a lot more listening, be attentive, and then don't write too much, okay? So remember, the adolescent is your patient, not the parent. So always try and connect to that adolescent before anybody else. Critical to remember to discuss confidentiality. Critical to mention the exceptions. So I'm going to keep what we say confidential. That means you should be confident that what you and I discuss stays here. Clearly, the level of confidentiality that you offer to a 12-year-old is nowhere near the level of confidentiality with an 18-year-old, right? But you still must have that space to have that confidential conversation. Without it, you really oftentimes won't know what's going on with that young person. But of course, if they have homicidal or suicidal ideation, if there's a history of abuse, if they have a reportable illness, they come back with a positive HIV, well, guess what? We can't keep that to ourselves. You come back with an STI of whatever type, we can't keep that to ourselves. And then if there are any other legal requirements, but always make sure that you have that discussion with both adolescent and parent together, so that the parent don't come to you afterwards and say, everything all right, doc, everything all right? And you have to be very careful to not say, oh, everything is good to go, because next month when you see the patient and everything is not good to go and you can't say that, it can be very tricky. Okay. Now, if and when you need to break confidentiality, do not sneak and break it. Simply tell them, boy, you remember that first time when we spoke about what I can and cannot keep confidential? We're right up in the center of that now, and I'm going to have to tell X or Y person. May not necessarily be the parent, right? Okay. All right, we don't have time for those. Essentially, bottom line with the interaction, after you've seen the adolescent alone, you don't speak to the parents alone. You can speak to them together, but after you see that adolescent alone, unless you have a very good rapport with your adolescent and they know that for the last 2 years you never breach confidentiality, then they might say, boy, doc, you tell mommy, because I don't think I want to be there to hear how she responds. And that's different. Okay. But you do want to wrap up and summarize the issues with both the adolescent and the parent, certainly as they get older. So when I'm seeing an 18 or a 19-year-old, I'm not wrapping up with the parent for the most part, right? Because this is a full-fledged adult who can then share what they need to share with the parent. If they want me to share with the parent, then I'm happy to. All right. Always make that effort to examine separately. And we do want to wrap up with the parent as they're growing up, because they want to be involved, but you have to guide them how to be involved. So don't tell them everything under the sun. You just say, we're working on some stuff. Otherwise, in true Jamaican fashion, the parent is going to follow up with the teenager and say, remember Dr. Harrison gave you so and so to do? That is so irritating to an adolescent, right? Because then it becomes work. It don't matter to me if they come back and they haven't done what I sent them to do, to think through, then that's okay. That's reason for conversation, right? Seeing the adolescent, it follows the same path. HPC, past medical history, social and family history, regular review of systems, and then we come to the psychosocial review of systems. So we did that. So here we go. Heads: home, education, employment, eating, stuff that you do, drugs, sex, suicide, safety. You'll have the lecture so you can go through all of them again. And you can look at this screenshot when you go through, and the same here. I've highlighted activities with media time. Do not forget to ask what they do on media. For drugs, there's a quick and dirty 2-question screen. Do you use? Do your friends use? If it's at early to middle adolescence, ask about the friends first. They're more likely to tell you what the friends are doing. Usually when they hit by about 16, 17, they'll tell you what they're using, if they're using. Okay? If they are using, then you want to go on to something more, which would be a craft screening tool. Are they in a car with somebody who is using? Do they use it to use alcohol or whichever substance to feel better and to relax? Do they use it when they're alone? That's particularly concerning. Are you using so much that you're forgetting things? You wake up and you don't know how you got to this particular room or how you ended up in this space. If your friends in particular are telling you, yo, you're drinking way too much, then you're having too much. And if you've gotten into trouble, suspension, expulsion, drape up by the police, whatever the case may be. Sexuality now, gender neutral questions. So if I'm asking Zaria about her relationships, I'm not going to say, so Zaria, do you have a boyfriend? Because then immediately it clues her in to think that I've assumed she's heterosexual, right? So can just basically simply ask, are you more attracted to girls, to guys, both, or you don't know? Some people will answer straight up. Some will look at you like, and you just say, listen, everybody gets the exact same question and I get different answers. I just want to know what space you are currently in, okay? And then you move it from there. If they say, some people will answer and say, well, I have a boyfriend. That has nothing to do with whether you're attracted to males, females, or both. So you may have a boyfriend as a girl, but you may also be attracted to girls. So do not stop your line of questions there, because sometimes they're just trying to brush off the question, okay? And if you feel like you can't push the issue at that time, that's okay. It's not like an urgency to find out what their sexual orientation is. It's not going to change tomorrow. So you can take your time, right? Quickly to just mention screening for depression, there are quite a few that you can use. Probably the one that we use most in practice now is the patient health questionnaire, which you can just use. The full thing comes with 9 questions, but you know, you've seen lots of patients, so you can start with screening everybody with these 2 questions. Have you noticed that, you know, you have little interest or less pleasure in doing the things that you usually used to do? And then, are you feeling more down, depressed, or hopeless? Quick, right? Screening for anxiety. You feel anxious, nervous, on edge all the time, having difficulty being able to stop or control how much you worry. And if either of these scores are over 3, then you move on to do more, okay? Now remember, screening is just to pick up quickly, but your clinical interview is going to be the gold standard, okay? Safety, you can go through that. Now, once we've gathered our information from our heads and our HPC and all of that, do we see no real major issues? Then we just do some health promotion, some anticipatory guidance, and we're good to go. If we see some issues, then we want to say, okay, how many concerns do we have? How many risk factors? How many risky behaviors are there? Let's work through the ones that are most critical at this point and determine whether it's something you can manage yourself or you need to refer on promptly, okay? If it's out of your league, just refer on. If you know that you don't manage well with teenagers and it's not going to be something that you're going to be able to give your 100% to, refer on, okay? This you can read through. All right, to briefly look now at disordered eating, because I don't think you'll get it anywhere else, and it's a growing issue. Typical growth curve, right? If you looked at this person, you're like, all right, all good. She comes and, you know, you do your physical and you fill out your school form and she gone. But if you had done your heads, you'd realize, she has some disordered eating behaviors. And then if you were able to pull records from previous visits at other doctors, you'd realize that although you're seeing her now and she's happily on the 25th, since she started dieting 6 months ago, she would have been up here because, you know, she'd been following her curve nicely. So she just took a nice precipitous fall right there. And when we see that, we know that something is up, okay? So we know that lots of people think that we don't have this issue in Jamaica. Maybe you are the converted people who recognize that we do, but you know, 1/5 of our young people have significant concerns where disordered eating is concerned. We have 8% that engage in self-induced vomiting and 3% that will use laxatives, diuretics, etc. Okay? They're at risk because remember we said they do a lot of peer-to-peer comparison. So there's this drive to look like everybody else. I always say I don't know why anybody ever created a size 0. Like, what the hell is that? How can you have 0 size? But some people want to get to that 0 size because it seems to be the place that you want to be, right? But in addition to that, those physical changes of puberty that come naturally, that change for girls from being lean, like boys, to now having an increased percentage of body fat. So less lean mass, more body fat. If they're not prepared for it and if it's not managed well by the people in their immediate sphere, it can be very traumatic for them and it can be a trigger for the beginning of an eating disorder. Males, on the flip side, more commonly will have a drive for muscularity, and so they can do some real crazy things in terms of excessive exercise and all the other things that come along with it, that are similar to the girls. Okay, so essentially it's unwarranted weight control measures, whatever that may be, and you may go in a restrictive pattern or you may go in an overeating pattern. Most usually in adolescence, and then it might go on if we don't manage it quickly, early, and effectively. So the three main ones: anorexia nervosa, bulimia nervosa, and binge eating disorder. The easiest ones to miss and the most prevalent, bulimia, because most of them are normal or slightly overweight, right? Binge eating disorder, they're going to be overweight, and anorexia nervosa, eventually, they're going to be underweight, so you won't miss them. The bulimia patients can continue for a long time. So eating disorders, really, you need to know about, because they're psychiatric illnesses with medical complications. So it can affect any and every system in the body. And essentially what you want to do is make sure you have an interdisciplinary team. No one individual can manage an eating disorder. It should be a team. And then you determine, okay, this is the diagnosis. We're going to involve the family. How are we going to work around this, whether it's outpatient, inpatient, etc. We don't have day hospital for eating disorders in Jamaica, but we do, nor residential, but we do have inpatient and outpatient treatment. Okay. And then really blazing through, hopefully Dr. Tomlinson is not waiting. I wanted to end on a positive note. So resilience-based approach. I think this is what you guys need to have for your own day-to-day life, but certainly to put it in place with how you work with a patient. So as you should know by now, resilience really is that capacity to bounce back. So unless you fall, you really can't easily develop resilience, right? Clearly, some people are born with more resiliency than others inherently, but it is something that can be learned. So for us, utilizing a resilience-based approach, you have to identify individuals' assets. So they may have 10 problems and one asset, and you are going to minimize the focus on those 10 problems and focus on that asset, so that if you can get that young person to embrace the asset, then you can move forward. So what do we look for? Supportive parents and family, right? Good self-esteem, an assertive young person. If they have academic success, if they're generally in good health, if they have good role models, if they have a peer group that is moving in the right direction, and if they're involved with some sort of religious movement. I don't mean attending church, I mean involved, very different. And then a personal sense of morality. Those are some of the factors that you want to identify and strengthen. Now for the family, you want to help them also as parents to know how to look for those pro-social skills in their adolescent. You know, we have an ability as parents in Jamaica to just always focus on negatives. So if I say to a parent, so mommy, tell me what he's good at, they can sit there in stunned silence for like 10, 15 seconds. What do you mean, Doc? What do you mean what I'm good at? Because we don't focus on that, right? But if I say, so what are the concerns? I get a list, right? So we need to change that mindset. And you want to stress to the parents that they really are that source of support, and it should be a positive relationship at all times. All right, so we blazed through that lecture. I am hopeful that you all got through hearing and understanding and didn't tune out or zone out. Are there any questions, guys? Okay, so you're all still quiet. Glenisha, any questions?
No, Doc. Everything was clear. Thank you.
All right. Okay, great. All right, guys, so Dr. Tomlinson Morris is in the large lecture theater, so please mosey along. And I will stop this recording. Have a wonderful holiday weekend. Take at least one day to just chill, and then the others you can do a little reading. Okay? Bye, guys.
Thanks,
All righty.